everyone. My name is Tia Smith, and I will be presenting on the posterior cruciate ligament sprain. So, our objectives are to learn about the structure of the PCL, define its sprain, understand the pathomechanics that lead to this pathology, discover the clinical manifestations and functional limitations of the PCL sprain, discuss the tests and measures related to the surrounding anatomical structures of the PCL, differentiate between similar diagnoses, and become knowledgeable on the rehab process and protocols of a PCL sprain, and to ascertain the probable outcomes of rehabilitating a PCL sprain. So the posterior cruciate ligament, what is it? It's a ligament that attaches posteriorly to the horns of the lateral and medial menisci on the posterior part of the intercondylar fossa of the tibia. It extends obliquely, medially, anteriorly, and superiorly to attach to the lateral surface of the femoral condyle. Because this ligament is covered by synovial lining, it is considered to be extrasynovial and intra-articular. The ligament is 50% thicker than and has twice the tensile strength of the ACL, and because of this, the PCL is very strong and less likely to be injured. Regarding osteokinematic influence of the PCL, due to its positioning, the ligament is most taut with great flexion of the knee, specifically the anterior lateral bundle, while the posterior medial bundle is taut in extension. When the knee is extended, the PCL has a decrease in its contribution to resisting posterior translation. The PCL is both a primary and secondary restraint to movement. For instance, it primarily restrains against posterior translation and internal tibial rotation, and it is a secondary restraint to external rotation of the tibia on the femur at 90 degrees of flexion, and assists with the rolling gliding mechanism of the tibial femoral joint, and resists varus and valgus forces at the knee after the collateral ligaments have failed. So, now we get into the basis of this presentation, the posterior cruciate ligament sprain. When defining the term sprain, it is referring to ligamentous injury and strain, tendinous injury. As stated earlier, the PCL is very strong. It takes a lot of force to injure it. Due to this, the PCL injury usually occurs as a result of significant trauma, such as a motor vehicle accident, specifically a dashboard giving posterior force into the passenger's knee, resulting in an excessive posterior translation, or a fall into the anterior aspect of the proximal end of the lower leg with a flexed knee. The mechanism of injury is an excessive posterior force, such as falling onto the knee when it's flexed, as I stated earlier, having posterior force strong enough to hyperflex or hyperextend the knee. And then something that I found that was interesting regarding the PCL is that there are two ligaments called the anterior posterior meniscal femoral ligament, the anterior and posterior. They're two different ligaments that originate from the same area as the PCL, but they have different insertion sites. So even if there's a mid-substance tear of the PCL, like the PCL tears in the middle of the ligament, instead of its insertion or origination sites, they will remain unharmed. Okay. Oh no. Okay. So for the pathomechanics of a PCL sprain, it may occur by forced knee flexion or falling into a knee that is flexed, and due to the ground reaction force having equal and opposite reaction directed posteriorly at the knee joint. This is also the same mechanism for hyperflexion injury of the PCL, but the knee will be in hyperflexion. Or another pathomechanics is by excessive hyperextension, which could result from landing awkwardly after jumping. And then lastly, as I stated earlier, the PCL sprain could also occur due to trauma, such as a motor vehicle accident. Okay, and then I have some videos that are so fun. Okay.
And as you kind of follow along here, you can sort of see his left knee impacts the ground right there, and then you sort of see the defender coming right on top of him.
And then notice how when he fell, the ground reaction force directed a force posteriorly onto his knee, leading to an excessive posterior translation of the tibia on the femur. And then also we have an hyperextension injury down here
George suffered a very painful and concerning looking right knee injury on his knee.
These are two of the ways for a PCL injury to occur: flexion and hyperextension. For clinical manifestations, the signs that may occur are a popping sound, an abrasion or contusion on the superior anterior tibia, swelling, a decrease in 10 to 20 degrees of deflection, and a positive posterior jaw, posterior sag, or quadriceps active test. Some of the symptoms that may, also positive posterior Lockman's test. Some of the symptoms that may occur are pain in the posterior aspect of the knee, which can be aggravated with kneeling. And on the other hand, during extension, pain is minimal, but increases when the knee is past 90 degrees of flexion. Additionally, patients may complain of feeling as though their knee is giving way due to the severity of the tear that may cause instability. If the PCL sprain is in conjunction with other structures such as the ACL and MCL, there would be a lot more symptoms, and I will address the symptoms that may occur of an ACL, MCL, and LCL sprain later on in the differential diagnosing section of this presentation. Some of the functional limitations a patient may face if they have a PCL sprain include knee instability, because the patient no longer has normal restraint to posterior translation of the tibia, which could lead to an increase in falls due to the lack of stability. Also, a PCL sprain could lead to great deviations such as decreased terminal stance, which could lead to a shorter stride length, decreased walking speed or falls, decreased knee flexion and internal rotation. The PCL sprain can also lead to decreased knee flexion and internal rotation, which may cause knee locking. And then other limitations caused by PCL sprain could be excessive hip adduction, flexion, and internal rotation, which could cause impingement. Okay. Some of the tests and measures you could have, or you could use to determine a PCL sprain are a posterior jaw, posterior sag, and posterior Lockman's, and also the quadriceps active test. And then some of the measures you could have are, you could perform a range of motion, manual muscle testing, muscle selective tension testing, and as far as imaging, an MRI is the gold standard. You can also perform a radiograph, which are important for acute cases. You can perform instrumented testing and stress radiographs. I inserted a video of a posterior jaw test. And as you can see, there is no structure limiting the posterior translation of the tibia on the femur. So we have a ruptured, grade 3, complete rupture of the PCL. Okay, for differential diagnosing, I wanted to focus on the other collateral ligament sprains. For the ACL sprain, it often occurs by excessive lateral force, and additionally, anatomy plays a role in an ACL sprain. For instance, if a person has a narrow intercondylar notch, joint laxity, or lower extremity malalignment, they are at an increased risk for an ACL sprain. And as far as demographics go, women are 2 to 8 times more likely to sustain an ACL injury when compared to men. In addition to excessive lateral force, ACL sprain may occur due to abrupt deceleration or a direction change. And then when diagnosing an ACL sprain, it's important to point out that unlike the PCL, the ACL is rarely isolated, meaning that oftentimes this injury occurs in conjunction with other structural injuries, such as an MCL sprain. Although in the rare chance that the ACL sprain is isolated, there will be local tenderness on the anterior side of the knee and quadriceps atrophy. And then when discussing pathomechanics, Dutton points out that it is not common for an ACL sprain or injury to occur with hyperflexion or hyperextension, unlike the PCL. And another hallmark sign of an ACL injury would be acute hemarthrosis. And then also diagnostic tests can be positive anterior jaw or Lockman tests. Okay, for an MCL sprain, it often occurs by excessive valgus force to the knee, meaning that the force begins on the outside of the knee and translates medially, unlike the PCL sprain. Additionally, unlike the PCL sprain, where it often occurs in isolation, the MCL sprain will often precede an ACL sprain, meaning that the two will often occur together, and rarely does the MCL sprain happen without another structure being injured. The MCL sprain can be confirmed by a positive posterior medial displacement valgus stress test or a positive valgus stress test when the knee is in 90 degrees of flexion and the leg is in full tibial external rotation. A common symptom of the MCL sprain would be tenderness along the medial aspect of the knee. With the LCL sprain, it often occurs due to an excessive varus force, so the force will be directed on the medial side of the knee, translating laterally. It can be confirmed by a varus stress test with the knee in 10 to 30 degrees of flexion and the leg in full tibial external rotation. Also, the modified posterior lateral jaw or a Luber test may be used to determine LCL sprain. And a common symptom of an LCL sprain would be tenderness along the lateral femoral condyle. When rehabbing a PCL sprain, there are two different options. If the PCL sprain is a grade 3, generally surgical intervention is favored, but if the PCL sprain occurs in isolation and is a grade 1 or 2, a non-surgical conservative intervention or treatment protocol is recommended. For the post-op protocol, I included precautions, but I don't really think that we go over precautions that much in this class. So, do you want me to go? Okay. Okay.
We'll come back to this in the interventions course.
Okay. So in the maximum protection phase, it's from day 0 to 1 month, and the main goals are inflammation, healing promotion, range of motion achievements such as the knee being able to achieve 90 degrees of flexion, and manual muscle testing achievements like the quadriceps being a 3 or better on the manual muscle test grading scale. The exercises to be implemented in the maximum protection phase are quad sets, ankle pumps, supine single leg raises, hip abduction, and abduction. I think it's important to point out that if there is a resistance to be applied during this phase, it should be to the proximal knee and not distally. For the moderate protection phase, 1 to 3 months, the achievements of range of motion are to have the knee being able to be flexed to 125 degrees, a manual muscle testing goal of the quadriceps being at 4 or greater on the manual muscle test scale. And then as far as exercise, at 2 months post-op, a stationary bike can be included. An intervention plan of care in addition to using a leg press with the knee being at a maximum of 90 degrees flexed. Also, closed kinetic chain exercises such as terminal knee extension and balance and proprioceptive exercises. For the minimum protection phase, which is the months 3 to 12 months, the goal, okay, for 3 to 9 months, the minimum protection phase is in total 3 to 12 months, but I divided it into 2 sections. So for 3 to 9 months, the goals are to make sure that the person is independently functioning with their ADLs and that they are able to return to low impact activities. And for 9 to 12 months, the patient should be able to return to normal physical activity, including athletes returning back to their normal workouts or any type of training they were doing prior to their injury. For the isolated conservative treatment, this is usually for grades 1 and 2. The goals are to restore range of motion and strengthen the associated muscles such as the quadriceps and gastrocnemius. It is important to point out that you do not want to begin hamstring strengthening for about 6 to 8 weeks during the plan of care in order to decrease the likelihood of the PCL being stressed. If one is to strengthen hamstrings during this protocol, it should only be through the closed kinetic chain to decrease the likelihood of shearing forces and to decrease the angle pull that the hamstrings have on the posterior tibia. Exercises that are to be implemented in the conservative protocol are squats, lunges, and closed kinetic chain extensions. Balance and proprioceptive exercises are also implemented, and if a patient is symptomatic, they may benefit from use of a PCL brace. For athletes, plyometric exercises can be introduced, and depending on the person, they may return to sport in 6 to 8 weeks, but on average, it takes about 12 to 16 weeks. So to limit probable outcomes in a surgical intervention, they may have a slower return to activity when compared to the conservative intervention, which makes sense because for surgical intervention, it's usually a grade 3 ligament sprain. A brace may be needed, and then there was a study done by Tucker et al. On military men who had PCL pathology, including minor and moderate sprains, and they found that afterwards, they had surgery, and found that afterwards many were unable to return to previous function level, and some even required revision after a short-term checkup. So surgical intervention may not always be the best intervention to provide a PCL sprain. And then also surgical interventions might not be the best intervention to provide when it's a grade 1 or 2 or a minor or moderate PCL sprain. Then also for conservative intervention, you have a quicker return to activity, again either 6 to 8 weeks, usually 12 to 16 though, and then you have a high return rate to sport. So in conclusion, the PCL is the least injured ligament due to the strength of the structure. The mechanisms of injury are trauma, flexion, hyperflexion, hyperextension, and rotation with valgus or varus force. A PCL sprain causes gait deficits, decreased range of motion, and decreased strength. The posterior drawer, posterior sag, quadriceps actor test, and posterior Lachman's test determine PCL pathology. An MRI is a gold standard for imaging diagnosis. We differentiate between ACL, MCL, and LCL sprains. We also determine rehab interventions for post-op and conservative treatment of PCL sprains, and we discovered possible outcomes of both surgical and conservative treatment. Here are my references. Any questions?